Clinical communication criterion C2, understanding and incorporating the patient's perspective, is where advanced international medical graduates bleed marks during the management phase of the consultation. Most candidates assume this criterion simply requires nodding along, repeating the patient's concerns back to them, or saying, "I understand." That is not what assessors are measuring. In the OET Speaking subtest, you are routinely given role-play scenarios where the interlocutor is explicitly trained to push back against your medical advice. They will cite demanding 12-hour work shifts, financial constraints, fear of side effects, or skepticism about medication. When a patient rejects your clinical proposal, your response determines your score. If you push back with cold medical stats, you fail. If you capitulate and abandon the medical task, you also fail. In this video, I will break down the 2 fatal mistakes candidates make when facing patient resistance and show you how to execute the collaborative compromise to secure your C2 marks while keeping your timeline intact. The most common error when a patient rejects a treatment plan is what we call the metric monologue. Imagine you are advising a patient with poorly controlled type 2 diabetes to overhaul their diet and start prepping fresh meals. The patient pushes back instantly. "Doctor, I work 12-hour night shifts at a logistics warehouse. I don't have time to stand in a kitchen prepping meals." A candidate trapped in a metric monologue ignores the patient's operational reality and simply repeats cold clinical statistics louder. Observe the live acoustic intercept on your screen.
Yes, but Mr. Davis, if you do not control your glucose levels, your HbA1c will remain dangerously high. This significantly increases your risk of peripheral neuropathy, kidney damage, and cardiovascular events. It is vital that you make time for your health.
Analyze what just happened. The candidate delivered accurate medical facts, but completely failed criterion C2. By dismissing a 12-hour night shift as a mere excuse and lecturing the patient on long-term pathology, you create immediate clinical friction. The patient feels unheard, resistance increases, and you waste 45 seconds arguing a point you will not win. Passing criterion C2 requires explicit constraint validation. You must treat the patient's real-world lifestyle barrier as a valid clinical variable, not an obstacle to argue against. Instead of lecturing, a passing doctor validates the operational constraint before updating the clinical target. Analyze the structural architecture of this masterclass alternative.
Mr. Davis, I completely appreciate how demanding those 12-hour night shifts are, and standing in a kitchen after a night duty is simply not realistic right now. Since full meal prep isn't feasible at this stage, let's look at a smaller, more practical starting point that fits directly into your current shift pattern.
Look at the mechanics. You did not drop the medical goal, but you explicitly acknowledged that a 12-hour shift makes standard meal prep impossible. You validated their operational constraint, closed the resistance loop, and immediately repositioned the discussion around a realistic compromise. The patient's defenses drop, and you remain in structural command of the consultation. The second major C2 failure is the exact opposite mistake, the passive surrender. When a patient pushes back strongly against a task on the candidate card, for instance, refusing to start a daily medication due to fear of side effects, candidates often panic. To avoid confrontation, they abandon the medical task entirely. Listen to this failing execution.
Oh, I see. Well, if you really don't want to take the medication because of the side effects, that's completely fine. We can just skip it for now and see how things go at your next checkup in 6 months.
This is a critical failure. By surrendering the clinical objective, you fail to execute the required task on your candidate card, and you fail to guide the patient safely. Empathy does not mean clinical abdication. Your job is not to capitulate, it is to adapt the pathway dynamically. The solution to patient resistance is dynamic task adaptation. You maintain the core clinical objective, but you break it down into a phased, low-friction entry point that the patient can accept. Analyze the pacing and negotiation structure of this masterclass correction.
I hear your concerns about potential side effects, Mr. Davis, and it is completely reasonable to be cautious. Rather than starting the full dosage today, what if we begin with a half dose for the first fortnight alongside a weekly check in with our clinic nurse? That way, we monitor your tolerance closely before making any further adjustments. How does that phased approach sound to you?
Look at what was achieved in under 20 seconds. You validated their fear of side effects, completely reasonable to be cautious. You adapted the task into a manageable trial, half dose for the first fortnight. You built in a safety net, weekly check in with our clinic nurse. You deployed an open verification question to secure active agreement. How does that phased approach sound to you? This is the exact definition of criterion C2. You understood the patient's perspective, incorporated their operational limits into the care plan, and safely preserved the clinical task. Understanding the patient's perspective is not about lecturing or surrendering. It is about clinical negotiation under strict temporal limits. If you find yourself running out of time during management, or if patient resistance consistently throws your consultation off course, your timeline mechanics need immediate calibration. Do not wait for exam day to test your pacing under pressure. Click the link in the description below to run my free timeline integrity audit. This interactive diagnostic tool will calculate your exact risk of a structural collapse and show you where your consultation layout is failing. Run the audit, lock in your structural boundaries, and I will see you in the next video as we decode criterion C3, providing structure.